Hi, so in this video, I'll be providing patient education with regards to scenario 17, which involved the 13-year-old female gymnast that was diagnosed with spondylolisthesis of the alpha vertebrae shifting on L5. So spondylolisthesis is a shifting of one vertebrae over another that leads to radicular or mechanical pain or symptoms. And the reason, well, this could be due to congenital, acquired, or idiopathic causes. And spondylolisthesis most commonly occurs at the L5S1 region, where the L5 vertebrae will shift on S1. The second most common place to see it is L4 shifting on L5, which is the situation we have here. There's five types of spondylolisthesis. The most common of these is known as ismic, which involves spondylolisthesis, which is a defect stress fracture of the pars interarticularis. Also, it's to be noted that this form of spondylolisthesis is most commonly seen in the adolescent or young adult population, especially with gymnasts as well. So I'm just going to provide a quick visual just to provide a better idea. So on the left is where you have the pars interarticularis, which is located between the pedicle and the lamina of the vertebrae. So if there is any form of damage or fracture at that landmark, as shown in the middle with the spondylolisthesis, then that could be a precursor to the spondylolisthesis, which is going to lead to the anterior shifting of the vertebrae since the landmark can no longer provide proper support. And if the vertebrae shifts anterior, that it'll lead to that excessive lordosis, which was mentioned in the assessment findings. So the most common mechanism of injury for spondylolisthesis, especially when talking about gymnasts specifically, is the repetitive extension and rotation movements, especially when it's combined with the impact that's placed on the low back from constantly landing on the ground. And the reason for this is because of the stress distribution that's placed on the pars interarticularis. It's highest when there is during extension and rotation movements. So with that being said, the pars interarticularis is going to be most vulnerable to damage and injury with the constant weight and repetitive stress that's being placed on the low back. So now that that's established, it would explain why, like it had indicated in the assessment findings, that there's the pain in back bending, jumping, landing, and the backflip, because with the back bending, you're going to have the extension that's going to be placing pressure on the pars interarticularis, the facet joints. So that's gonna increase the lordosis, and as well the anterior slipping of the vertebrae. Even with the jumping and landing, it ties in with the impact that the low back is having to absorb. Even with the backflip, it involves a combination of doing a vigorous hyperextension to start the movement, and then finishing it off with a high impact landing, which again you're placing pressure and impact on the low back. So with the excessive lordosis and pain in the area, it's going to cause the erector spinae to shorten and tighten up, because it's going to form a bracing mechanism, especially because of the low back in the area. So that's going to compress some structures in the area, including inner tissue, like the nerve roots. It's going to compress the nerve roots, and as well, since with the lordosis in the area, it's going to lead to shortening of the hip flexors, especially the psoas, because of its lumbar attachments. So now you're going to have now you're gonna have the tightness of the hip flexors, the erector spinae, and the lordosis, which is all gonna cause an anterior pelvic tilt, and with that anterior pelvic tilt, it's gonna lead to lengthening of the abdominal muscles, uh, which which is not going to allow the abdominal cord to function properly, which would explain why, like I mentioned, the assessment findings, there was difficulty with performing a proper plank because the abdominal muscles can no longer provide proper support, especially the rectus abdominis or the obliques that attach at the pelvis. Those especially are being in a lengthened position. Uh, and then if we go back to the posterior side, you're going to have the hamstrings. They're going to be in a lengthened position and overactivating to try to pull the pelvis back down. Finally, it was mentioned as well in the assessment findings that there was weakness and bilaterally in ankle dorsiflexion, uh, toe extension, and even lack of sensation of the dorsum of the foot. And the main reason for that is, like we mentioned before, there's nerve roots being compressed, especially L4, L5, which I'll provide a quick visual as well, just to again provide a better idea. So yeah, it's to be noted with L4, the L4, L5 nerve root, with regards to their dermatomes, uh, they both involve the dorsum of the foot, which would explain the lack of sensation at the dorsum of the foot. And further myotomes, they both involve ankle dorsiflexion and toe extension, which would also explain why there's a lack of innervation uh, further to perform those actions.